welcome to everyone here. It's a real delight to be able to welcome you all to the 8th annual Norman R. Seay Lecture, sponsored by the Knight Alzheimer's Disease Research Center at Washington University. And many of you know the importance of Mr. Seay for the efforts that the Knight ADRC has exerted over the past 12 years to try to improve the diversity of staff, faculty, and participants in research directed against Alzheimer's disease. And we're particularly interested in doing so not only to be proportionate in terms of representation in the St. Louis City population, but also because African Americans likely are at greater risk of developing dementia and dementia caused by Alzheimer's disease. And if we don't study the reasons why that might be so, then we have lost an opportunity to try to make a serious illness better for individuals in the St. Louis community. A little bit of feedback. So I'm here, and I didn't introduce myself. My name is John Morris, and I have the honor of being the director of the Knight Alzheimer's Disease Research Center. And again, I want to thank everyone here, not only on behalf of the Alzheimer's Disease Research Center, but also on behalf of Links Incorporated, the St. Louis chapter, including Mary Thomas and also Ida Goodwin Woolfolk, who Ida has succeeded Mr. Seay as the chair of our African American Advisory Board in the ADRC. And we are very appreciative of the support of the Links in our efforts, and indeed they are hosting the reception that will be held right after the lecture today. So when Mr. Seay decided to step down as the inaugural chair of the African American Advisory Board of the Alzheimer's Center, that's when we began this annual lectureship in his name. And so we're very pleased to see all of you. I remind you, please, to turn off your cell phone or pager. And I'm also told that if anyone parked in the south garage, that we can validate your parking tickets. It's a real honor for me to welcome the Executive Vice Chancellor for Medical Affairs at Washington University and the Dean of the School of Medicine, Larry J. Shapiro, who's just beginning his second decade of the dean here. And he is going to also welcome everyone to this lecture. So let's thank Dr. Shapiro for coming.
Well, thanks, John. And it is a delight to be here. I always look forward to this lecture each year, now the 8th annual Norman Seay Lectureship. And this one is a particular pleasure for me because we get to celebrate, and I get to see two of my heroes. One who is probably too young to be my hero, but Consuelo Wilkins returning home to Washington University and to St. Louis, and getting a chance to catch up with her and hear of her many accomplishments. And of course, this lectureship honors Norman Seay, who probably requires no introduction to this audience, but there are a few younger folk in the room, and I'm not sure we all recognize what a giant is in our midst. In addition to being the inaugural chair of the African American Advisory Board of the Knight ADRC, Mr. Seay has had a few other accomplishments in his long and successful career. Among other things, he worked for the United States Public Health Service for 10 years in Washington, and while there, he was part of the group that actually helped start and establish the Martin Luther King Day celebration that we all now recognize. In 1984, Mr. Seay returned to St. Louis, became executive director of the St. Louis Housing Authority, and then the director of the Office of Equal Opportunity at the University of Missouri St. Louis for 15 years. But I can't let it pass that we just a couple of weeks ago celebrated the 50th anniversary of the famous Jefferson Bank demonstration that really changed the face of the civil rights movement in the city of St. Louis. And as we, I hope, all recognize, Mr. Seay was a leader, a proud leader of that event. Again, for those who may not be aware, the Jefferson Bank had recently relocated its operations from the corner of Jefferson and Washington to Jefferson and Franklin, and somehow in the process managed to rid itself of all African American tellers and other people who worked at the bank at that time. It had been the only one among several St. Louis African American neighborhoods that employed African American professionals. And so there was a protest, an orderly, dignified protest, and according to historical accounts, 19 of the protesters were arrested, one of them being Norman Seay, and that won him 90 days in the St. Louis jail and city workhouse as a statement of principle. But it changed things in St. Louis, and it changed things in America. And of course, we're recognizing this year, hard to believe for some of us who remember those days well, 50 years of change in American civil rights. And as I said, one of those giants in that movement is with us today and is one of the people we honor. Mr. Seay has also contributed a lot to the development of the Alzheimer's Disease Research Center and its programs, and that's why this lectureship was established, and it is such a pleasure to honor him. I also want to take just a moment to acknowledge the accomplishments of the Knight Alzheimer's Disease Research Center and of its leader, John Morris, who has served admirably in that role even longer than I've been dean. I think he's older than I am, but I'm not sure. But clearly, this enterprise has established itself as one of the preeminent institutions in the world devoted to the study and to the advancement of treatment for Alzheimer's disease. Alzheimer's disease, again, I don't have to even begin discussing with this group the importance that it holds for individuals, for family members, for caregivers, for this nation economically. It's become a global problem as the world's population is aging and things are becoming more frequent. And I'm so proud that Washington University has such a leadership position in many areas in terms of advancing research and advancing care for this devastating disorder. And again, I just want to acknowledge John and his leadership that has brought this institution to great heights. We all have great hopes, and I think you'll be hearing, you have heard and you will be hearing about clinical trials that are underway and a variety of other efforts that I believe hold enormous hope and promise for improving the outcomes for patients and family members who suffer from Alzheimer's disease. So without further ado, I will invite Dr. Morris back to the podium so that he can introduce our guest. Hard to refer to Consuelo as a guest, but our guest speaker for today. So thank you all very much.
So as Larry mentioned, it's a homecoming of sorts, and a great pleasure for all of us who know Consuelo to invite her and to be able to have her here as our 8th Seay lecturer. Dr. Wilkins is currently the Executive Director of the Meharry Vanderbilt Alliance, a strategic partnership between Meharry Medical College and Vanderbilt University Medical Center in Nashville. Dr. Wilkins assumed this role on June 1st, 2012, and she holds appointments as Associate Professor of Medicine both at Meharry Medical College and Vanderbilt University School of Medicine. She graduated magna cum laude from Howard University in Arts and Sciences, and then stayed at that institution where she received her MD in 1996. I know that she is a very staunch alum of Howard. So she then went to residency in internal medicine at Duke University in North Carolina, and then came here to do fellowship in geriatric medicine at Washington University School of Medicine. When she left for the position in Nashville, she was associate professor in the Department of Medicine in the Division of Geriatrics and Nutritional Science. Among many activities, she served as chair of the Affordable Housing Commission for the City of St. Louis, been a very active member of the United Way of Greater St. Louis on the board of directors, and a health editor for the St. Louis American newspaper. And many of us in this room know her as a colleague because for many years she was a clinical investigator at the Knight Alzheimer's Disease Research Center. So let's all of us give Dr. Wilkins a warm welcome back to St. Louis. Dr. Wilkins. If I can invite Mr. Seay and Dean Shapiro, we'll have a quick photo op here.
I'm the elder of the three.
All right, so this says the 8th Norman R. Seay Lecture, October 1st, 2013, presented in appreciation to Consuelo H. Wilkins, MD. So,
No, you.
you're the star.
Okay. 1, 2, 3. 1, 2, 3. And one last one right here. 1, 2, 3.
Good afternoon. I'm delighted to see so many friends and colleagues here. I'm excited to see so many people. Hopefully I can remember what I was supposed to say during the talk. So first, I want to thank John and the ADRC for inviting me back, and to Larry for the kind words. Special thanks to the African American Advisory Board, which I had the pleasure of working with many of you for years, and also had the opportunity to chair the Seay Lecture Committee. So this is indeed a pleasure for me to return. Wow, I'm really seeing so many people. It's hard to concentrate now. It's great again to be back at Washington University, especially to talk about Alzheimer's disease and to honor Mr. Seay, who I had the pleasure of knowing and working with. And for those of you who don't know him personally, I had the opportunity to get phone calls from him. And I soon realized that I never knew if the phone call was going to be congratulating me on doing a good job or telling me I should have maybe thought about a different approach. But I always knew that if he took the time to call me, then it would be great advice and direction, and I really appreciated that. Sometimes I got calls from people in the community who read the St. Louis American and some of my commentary, and they were not as kind when they criticized my comments. So I do appreciate that, and Thank you for your leadership. I'm not sure if we'll have another time to acknowledge your family that's here as well, your sister and sister-in-law. Thank you for supporting Mr. Seay and all of his efforts. And as I know how families get pulled into doing other things, so it's great to have you with us as well. Hopefully, I didn't drum up too much anticipation about what to expect with these 3 keys. Some of you may expect that when you leave, you'll know all the answers and be able to eliminate the disparities in Alzheimer's disease. That is my hope. I don't think it'll happen in the next couple of days, but I do want to share some of my thoughts with you about that. My disclosures, I have received research funding from the NIH, Hartford Foundation, and since I've been at Vanderbilt, also some funds from there. So what I'd like to do is to talk about disparities first, in general, talk about disparities in Alzheimer's disease, and then I'll talk about the strategies that I think are important as we try to reduce some of the disparities in Alzheimer's disease. So what are disparities? There is not actually a lot of debate about the definition of disparities. There is a little bit of concern from those of us who do research in health disparities about whether or not we should be using the nomenclature of disparities or inequities. So disparities are differences, and it doesn't really speak to what the cause of the differences are. So if, for instance, we point out that there is a difference in the number of minorities, of African Americans who have Alzheimer's disease compared to whites, then that doesn't tell us much. But in the simplest terms, health disparities are differences in health outcomes between any of these groups. So that could be based on socioeconomic status, race, ethnicity, geographic location. So I've now moved to the Bible Belt, which is also the stroke belt, gender, disability status, sexual orientation, or any combination of those. What about health inequities? Most countries in the world don't talk about disparities, they talk about inequities. So again, disparities are just differences. But when we talk about inequities, then we're really focusing on the fact that there are systematic and unjust reasons for the differences. So health inequities means that there are other issues that are underlying the differences that we see. So some examples of that could be unequal access to education, to health care, to housing. We'll talk a little bit about social determinants of health, but if there is unequal distribution of these resources, then they can also impact the differences that we see or be underlying motivations or drives for some of the differences in the health outcomes that we see. Racial discrimination is certainly one of those causes of inequities. So what are social determinants of health? This has become somewhat of a buzz term over the last 5 or 10 years, people focusing on what other things influence health outcomes. So these are things that I learned pretty quickly after, medical school and residency. Then we actually really think about how people interact in their day-to-day life. So typically, from the standpoint of someone who's in training, all we really think about is the person that we see in front of us. So the patient, what their disease is, what medication is going to be best to treat this condition, their high blood pressure or their diabetes or their Alzheimer's disease. But in reality, there's so many other issues that a person has to think about as it relates to their health. So it's probably been 10 years now since I was at a meeting at the Urban League of St. Louis, and there was a discussion about what are the most pressing issues for African Americans in St. Louis. And there must have been maybe a couple of dozen of us in the room, and only 2 of us were in health. So we were supposed to get into these small groups, talk about, what are the top 3, 5 priorities that we should think about that are issues for African Americans in St. Louis. Of course, I'm thinking health. Yeah, that's got to be the top thing. But in my circle, there are people who are from education, who are in the justice system. And so everybody thought that their issue was the most important one, no surprise. But I was actually very surprised at how low on the list health was. So again, in my very focused tunnel vision, all I see is if your blood pressure is high, well, that's got to be the most important thing in your life right now. But for many people, they don't even know that they have high blood pressure, and they may not have symptoms. But that's even the case for some other conditions that are more obvious. You get a diagnosis of cancer. For some people, that's still not the most important thing for them. So listening to people say, well, it doesn't really matter if I have high blood pressure if I don't have any food, or if I can't pay my rent, or if I have to take 3 buses to get to my job, and can never get home in time to see my kids' activities, after school activities. So being able to think about what patients feel, what they experience, really is important, I think, for us as health professionals, but also for us as researchers as we think about what are we going to be able to do to come up with diagnostic tools and interventions that really work in the real world setting. So this is one of my favorite slides. It's from a CDC publication, and it's 2 trees, obviously. On your left is a tree that's pretty barren, and you can obviously see lots of conditions that are prominent. Violence, HIV, AIDS, stress, all of these things are conditions that are prominent in this tree. What you see down here in the roots are discrimination, unemployment, segregation, poverty. All of these things are contributing to the lack of leaves on the tree. On the right, all of the conditions that are here are also on the tree on the left. What's the difference? There's so many leaves, there's so much greenery that you don't notice them as much. And that's because here they have quality schools, they have access to healthy food, access to health care, quality housing, they have jobs, they have insurance, and that leads to what? A sense of community, social networks, social support. All of these things make for a very different looking tree as opposed to the one that has fragmented systems and disconnected members and a feeling of powerlessness. So we can't think about how to treat the conditions if we're not also considering what the other factors are involved in the life of the individuals. So disparities, what about differences in Alzheimer's disease? First, I'll start with a definition of Alzheimer's disease. It's a type of dementia, and that's probably one of the most common issues when we're dealing with educating the community about Alzheimer's. Is it dementia? No, it's not dementia, it's Alzheimer's. Oh, no, it's not Alzheimer's, it's dementia. Oh, it's senility. And so what's the difference? What makes sense? So Alzheimer's disease is a type of dementia. So everyone who has Alzheimer's disease has dementia. But there are many different types of dementia, dozens of different types of dementia. So Alzheimer's disease is not the only one. Alzheimer's disease, though, is the most common cause of dementia or form of dementia, and it's characterized by memory problems, changes in behavior, which typically begin subtly and progress over time. Now, the other point I want to make about the difference between dementia and Alzheimer's is that there seems to be, I think, not necessarily culturally, but in the lay communities, and also among physicians and clinicians, people would rather say dementia than Alzheimer's. I think that's changing over time, but the perception is that Alzheimer's has no cure, there's nothing we can do about it, so we'd rather not say Alzheimer's. But most of the dozens of kinds of dementia also have no cure. So it's not necessarily any better to say you have dementia as opposed to Alzheimer's. The key thing is to understand what the underlying cause is. And right now, Alzheimer's actually has the most approved treatments. So not saying that you want to have a dementia, but you want to know what the underlying cause is. And so you shouldn't be concerned if a family member is told that they have Alzheimer's. And then we can also get back to people think you can't really have diagnosed Alzheimer's unless you have brain tissue. And I know Nigel wants all the brains, but Dr. Morris can tell you that the Alzheimer's Disease Research Center here is more than 90% accurate with diagnosing Alzheimer's disease without having your brain yet. So the key thing also is that Alzheimer's is not a normal part of aging. You should not expect to get Alzheimer's disease. Again, it worsens over time, and the most common symptom early on is difficulty with recall of recently learned information. So we'll get to some bad news. So about a little over 5 million people in the United States have a diagnosis of Alzheimer's disease or are believed to have Alzheimer's disease. The likelihood of you developing Alzheimer's disease increases with age. About a third of people over 85 have Alzheimer's disease. And this is where the disparities you start to see. So there are a number of reports, but I think this is probably pretty well accepted at this point that African Americans are twice as likely to have AD. Hispanics are 1.5 times as likely to have AD, Alzheimer's disease, compared to whites. So these are, thank you, Jocelyn, and I saw others from the Alzheimer's Association for making these nice graphs for us. The Alzheimer's Association is updating these every year now with the facts and figures. So I borrowed their slides here, their pictures here for this. So you can see there's a steady increase in the number of people who have Alzheimer's disease. The yellow or gold color represents people over the age of 85. This is what's happening to the United States. So our population is aging. There are more people who are over the age of 65, and over 85 is the fastest growing segment of the population, or at least it has been recently. So if we look at the proportion of people with Alzheimer's disease, and this actually includes other dementias as well, but predominantly it's Alzheimer's disease, there are some differences. So in African Americans, that's purple, and Hispanics, gold. I didn't come up with the purple and gold, so just letting everybody know that. This darker gray represents white Americans. So you can see that the prevalence increases with age, but look at how large these numbers grow. So African Americans over the age of 85, 58.6, and that's Hispanics, 62.9. But this is not trivial. So among whites, 65 to 74, that's 2.9. So by the time they're over the age of 85, that's 10-fold increase. So these numbers are huge, not just for minorities, but for everyone. And that's one of the reasons it's great that there's a thriving Alzheimer's Disease Research Center here so that we can be involved and help move towards solutions, strategies for early diagnosis, and hopefully treatments, and I won't say the C word. Cure, that's cure, sorry, I did say it. So look at this also. So this is cause of death difference between 2000 and 2010, Alzheimer's disease, cause of death due to Alzheimer's disease dramatically increased. All of these other conditions, it's decreased. So that's stroke, prostate cancer, breast cancer, heart disease, HIV. It's a pretty big number for HIV. The cause of death has decreased for all of these conditions, but it's substantially increased for Alzheimer's disease. So what are some of the risk factors for Alzheimer's disease? There's some well-documented ones, family history, genetics. If you have a risk for heart disease, including diabetes, hypertension, high cholesterol, these are also risk factors for Alzheimer's disease. Educational attainment has been associated with Alzheimer's disease, so the less formal education you have, the more likely you are to develop Alzheimer's disease. Social and cognitive engagement, so the less socially active and cognitively active you are, the more likely you are to get Alzheimer's disease. And if you've had traumatic brain injury, that increases your risk. So when we talk about disparities, again, a lot of the things that I showed you related to social determinants of health, housing, geographic location, those are often associated with race, but there are actually not that many conditions that we can link biologically to race. Vitamin D deficiency is one of them. So if you have darker skin, you are more likely to have vitamin D deficiency, and that's because of a biological reason. You require more sun exposure to make vitamin D if you have, the more pigment you have in your skin. So that's actually one of the few conditions that we know there's a biological reason for people of African descent or people who have darker skin to have differences. This is work that we did here at WashU, and I know Stan is in the room as well. Stan, I wouldn't say twisted my arm and pushed me towards vitamin D, but he was very interested in vitamin D when I came here as a fellow, and I became more interested in vitamin D as well. We were able to show here that there was an association between vitamin D deficiency and cognitive impairment, but we were also able to show that there was an interaction, so there was an added effect in African Americans. So I know you probably can't see this, it looks a little fuzzy here to me, but we were able to show that folks who had vitamin D deficiency and who were African American had a greater risk of cognitive impairment. Now, we're not quite sure what the cause of that is or what the underlying physiology, pathophysiology might be. One hypothesis is that people who have darker skin don't just become vitamin D deficiency when they get older. They may have had lifelong vitamin D deficiency, and perhaps that has some role in decreasing their memory and thinking. That's just for us pro-vitamin D folks, we'd like to say that. Genetic risk of Alzheimer's disease. The other issue, again, biologic and then genetic. So there's been a lot of interest in genetics as it relates to Alzheimer's disease. ApoE4, that's a specific gene that we've known for a long time is associated with Alzheimer's disease. But this study that I would talk briefly about was just published earlier this year. And I think it is a great representation of what is required for us to do research in this area. So there are almost 6,000 African Americans in this study. Not all of them had Alzheimer's disease. I think about a third of them did. And this study also found that there is another gene that seems to be more prevalent in African Americans who have Alzheimer's disease. We're just learning about this. I don't know if Allison is here or if others who are in the room know more about genetics than I do, can answer your genetics questions if you have any. But this is really significant in part because look at this. This is the front page of the first page of this paper. And this talks in technical terms about what I just said. This specific gene is associated with risk of Alzheimer's disease in African Americans. Look at the list of investigators, the list of scientists who are involved in writing this paper. And that still says for the Alzheimer's Disease Genetics Consortium. So they had to pool lots of data in order to actually come to some conclusion and analyze the results. This is important because as we looked at that 5.2 million people in this country who have Alzheimer's disease and the increasing number that are African American, it took data being collected from 1989 to 2011. We had to pull that much data to actually understand this. And so if we don't have more people involved in research, it will take us more and more time to actually get results and answer some of these questions. I will point out quickly that you may recognize a few folks here, those of you who've been coming to the Seay lecture. Patrick Griffith was a Seay lecturer, Lisa Barnes, Jennifer Manley as well, and then Allison Goat, who has led genetics in the ADRC for quite some time, are involved in this study. So disparities in diagnosis of Alzheimer's disease. We do know that for a long time, it's been recognized that African Americans and Hispanics, I keep saying these two groups because there's much less data about some of the other racial and ethnic minorities. And because the numbers, though, however, are growing, people with more Alzheimer's disease will probably have more and more data for those groups. So there has been a delay in diagnosis of Alzheimer's disease in these two groups. So people tend to present later, acknowledging that there's some problems with their memory. And part of that is we think culturally we may expect our older adults to have problems with their memory. And then we also just take care of them. So not that this is unique to these two groups, but mom or dad, grandma and granddad having problems with their memory, thinking, what do? We just jump right in and help them. We give them what they need, we take care of them, and we don't bring attention to it. There's also lack of information. There are false perceptions about whether or not there are diagnostic tools. Do you need to have brain tissue or not? What the treatments are that are available. And then there's structural barriers. Some of them relate to the social determinants of health that I mentioned. This is also some data that I collected and that I was involved in looking at brain tissue. This is, we wanted to compare the brains of African Americans who had Alzheimer's disease to whites who had Alzheimer's disease. This is published back in 2006. Boy, that was a long time ago. You can see it's actually a very small study, 10 African Americans and 10 whites. What we found, though, and why this got published in a really good journal, the Archives of Neurology, is that there are so few studies that can compare brains of African Americans to others. So what we found, though, in the study was that there's no difference. So the brains of African Americans with Alzheimer's disease looked like the brains of whites with Alzheimer's disease, except for a trend towards more amyloid angiopathy. That's a fancy word for you. What that means is amyloid is one of the two proteins that we see in Alzheimer's disease, amyloid plaques, or deposited in the blood vessels in the brains more often in blacks than in whites. We believe that this might be due to the fact that all of the African Americans in our sample had hypertension. And so hypertension has been associated with this change in the blood vessels. We're not sure if this is something that we would see if people didn't have hypertension. Again, because there's just not a lot of studies, not a lot of brains. I am pushing for you to donate your brain, and John is not pushing me to say that. But this is important for us as we try and learn more about the condition. One other thing I'd like to point out, so these are 85-year-olds. So it's not a young group. These are people who likely died because of conditions related to their dementia, although I don't know that, so I shouldn't say it. But specifically, I wanted to show you that the African Americans are higher educated in this group, so 16.7 years. So the average of the group had college degrees. And that's what we've seen a lot in many studies, not just related to Alzheimer's, that African Americans and minorities who participate in research tend to be higher educated. This is some data from Jennifer Manley, who again was one of the Seay lecturers, that points out why it's important for us to have a broad range of a sample of folks who represent a broad range, not just specific characteristics. For instance, if our goal is to increase minority participation in research, it shouldn't just be specific minorities. We need a broad range. So what Jennifer Manley and their group in New York found is that if you look just at race, you do see that there is an association with Alzheimer's disease. But there's stronger predictors of Alzheimer's disease. One, education, but then even a stronger predictor is your reading level. So we have to be able to understand what some of the other predictors are so that we can focus our screening efforts, but also we can think about how we can prevent or increase awareness about Alzheimer's disease among certain populations. Disparities in treatment. So cholinesterase inhibitors are the most commonly prescribed drugs for Alzheimer's disease, and it's been found that African Americans are 30% less likely to be prescribed cholinesterase inhibitors. We're not quite sure why that's the case. African Americans and Hispanics are more likely to stop using this class of medications within 6 months or after 6 months compared to whites. Again, we're not sure why. We don't know if they're having more symptoms or side effects, if they don't understand what should happen when they take these medications, if it's not clear that this is long-term treatment that's required. We're not sure. Memantine or memantine is the other medication that's approved to treat Alzheimer's disease, and it's also been shown that African Americans and Hispanics are less likely to be prescribed this medication. So we've talked about disparities. We've talked about disparities in Alzheimer's disease. Now to the 3 things that we can do to reduce these disparities. First is patient-centered education and care. Well, what does that mean? So we've talked some about race and social determinants of health. Race is mostly a social construct in this country. So we often, historically in research, we've classified people, we've compared them by race because that was all we had. We didn't have information about their educational attainment, we didn't have information about their literacy level, their access to health care. We didn't have other things, but we had race, and sometimes it wasn't self-reported race, it was observed race, and so we classify people by their external characteristics, and we're not really sure what that means. Most people, I would say anthropologists in particular, will tell you that race is not, race especially in the sense of African Americans, doesn't mean much ancestrally. So being African American typically means that you have African ancestry, European ancestry, and also some Native American ancestry. So again, what does that mean? Are we linking real biological issues to race, or are we using race as a proxy for more likely to be in a neighborhood that doesn't have healthy foods, more likely to be in a food desert, more likely to not have access to healthy or jobs or quality schools? Are we linking race to these other social determinants of health and then saying that these are real characteristics of a race? Even if we were to say that race is important, how is it important and why? But within any race, there's a wide spectrum of variability. So what do I want for my options for healthcare are going to be very different from other people who self-identify as African American. Has nothing to do with a biological reason. It's personal preference. So we can't take a broad brush and paint everybody in a specific race or group the same, because we're all individuals. So how do we do that differently? We need to think broadly about how to adapt and tailor our educational information. You know, what is your preference? What is your reading level? How would you prefer to consume information? Is written information going to work for everybody? I think the younger folks now are not going to read anything. It's all going to have to be on their podcast or something, or we'll have to have Twitter messages about Alzheimer's and how to get screened. I don't know how we're going to diagnose Alzheimer's via Twitter, but maybe somebody else will figure that out. We also have to disseminate health information in a different way. For those of us in academia, we focus on publishing in a journal, publishing in a high-impact journal. That's worth a lot, but that typically doesn't get information to the community. We've certainly shown through a number of efforts locally that community-based media, specifically, I've worked a long time with the St. Louis American and increasing their health focus, was a great way for us to educate the community about what resources were available, also what they should know in general health information. We have to have diagnostic tools that have been validated in patient populations that represent everyone. There are a couple of tests, cognitive tests in particular, that are sensitive to this. There's one word list that patients are asked to remember, and it has some things on there that I know my grandmother would never recognize, including fruits and vegetables like papaya, or spices like coriander. So if she's given that list, if she were given that list of things to remember, she may not remember because she's never heard of them. She doesn't associate those words with things. They don't have a place in her brain yet. So in 2 minutes, if she had to recall those, Corey something, I don't know what it was. So is that really an appropriate way to assess her memory and thinking? No, so we have to think about that broadly as well. The key will be individualized, tailored care, which I think is scary for those of us who provide care and those of us who have to pay for care or find ways to pay for care, because it's much easier to put people in a box than to tailor it. It takes a lot more time to see a patient and tailor it than it does to do a quick 10-minute office visit. So research that includes underrepresented groups, I've talked about that already. Less than 5% of participants in Alzheimer's clinical trials are non-white. So this data is a little bit old. I think this is from a study that was in 2006, a meta-analysis. So that number might be a little bit higher, but I doubt if it's much. So if we're expecting to apply the results of clinical trials to this growing population of minorities with Alzheimer's disease, then we need more of them to be in these studies. We need to know, is the reason that African Americans and Hispanics are not taking their medicine at 6 months because there's some side effects that may be unique to the group, or there's some social determinants that are affecting that? We have to be able to understand that. This is work from Monique Williams, who did this while she was in St. Louis, that identified some barriers and themes related to barriers in participation in research. Some of them are not new or unexpected: mistrust, access to information, so education, fear about the unknown, certainly fear about adverse events, inconvenience, so getting in and out of a major medical center is often less than convenient. And reputation of the researcher and the institution. So these are things that are certainly considered. So how can we do better? How can we engage more underrepresented groups? We have to engage them early. So the concept of community engagement, inviting community members to the table to discuss this early on, having an advisory board, but also having people who are able and willing to sit with you and tell you honestly what they think about your study, and the idea that you're going to have them come in every 2 months to have some weird blood tests done is not really appealing to them. Certainly starting with education and awareness is important. I mentioned including target audience in the planning stage. This is something that I've been able to start to develop at a little bit more in my new position, is to have a process that actually brings in community members and patients to provide input to the scientists as they're developing their research. We call it a community review board. We compensate the community members when they come in to do this. We provide orientation to them before they get there. We also provide the scientists some training on how to communicate with the community. They don't necessarily think that we're doing it. We just kind of sneak it in there, that they have to present it this way. Oh, no, you have to use our slides. And no, that language won't work. So they don't really know we're telling them that they're wrong. So that's how we get away with it. And then dissemination of best practices. So this is fairly complicated, I would say, but really just to show you, and I have another slide about this too, the time it takes to get from original research. There are a lot of dropout points here. So we do the research, it gets submitted to a journal, it may or may not get accepted, then it gets published, and then we're a little bit better now with disseminating because everything is electronic, but in a 2000 study, it was shown that it takes about 17 years to get from here to here. So we do the research, and then to actually get it implemented in practice takes 17 years, and that's way too long. We can't wait that long. And that's not even all of the research, because there's so much dropout along the way. This is another way of looking at the same thing, but this shows some of the other factors that are associated with that. So whether or not I get promoted in my career, what's important to the community, what are the priorities. There have to be changes along this pipeline if we're actually going to speed the process. So community needs to be involved here. Clinicians need to be involved here. So the doctors who are going to have to do the test, order them, order the treatment, have to be involved early on before we get to the point of telling them, well, we know this is the best thing for you to do, and then realizing that they're never really going to do it. I've talked a little bit about what we can do, and that's, again, making sure that we understand what the priorities are, but designing research that's practical and real world. So if you missed the 3 key points, here they are again. Patient-centered approach. We have to individualize our approach to both education, diagnosis, and treatment. We need to increase minority participation in research. We have to have a more inclusive group, and we as researchers need to think about strategies to overcome those barriers. And then we need to develop ongoing partnerships with clinicians, understand their priorities, and other things that we can do to actually improve the dissemination and implementation of the research and best practices once we are there. So, if anybody needs to reach me, feel free to contact me. Thank you for your time.